Welcome to lecture number 12 of the cardiovascular section of the integrative systems physiology course. Today we'll be covering oxygen delivery and the quantitative calculation of oxygen content in the circulation. And so again, when we're looking at the vasculature and circulation, including the cardiac system, a primary purpose of the cardiovascular system is the transportation of oxygen. Of course, a number of other significant purposes of the cardiovascular system, which include the removal of metabolic wastes, delivery of signals, including hormonal and paracrine signals, as well as delivery of immune cells to the sites of inflammation or infection. Of course, we don't necessarily touch on those as quantitatively as we do with oxygen delivery and matching metabolic demand to oxygen supply. So when we're looking at oxygen supply, big question here, of course, we've addressed this a couple of times, is how much oxygen does your body actually utilize per minute? We've got a couple options here across a very broad range. And of course, the answer that should be evident by this point is about 250 milliliters of oxygen per minute is your basal oxygen consumption for a roughly 70 kilogram male. When we ask the question, well, what's the major carrier of oxygen in the blood? You've got two options there, one being hemoglobin and the other being plasma. As we've discussed before, hemoglobin can carry about 1.34 mils of oxygen per gram of hemoglobin. With plasma, you can only carry about 0.003 mils of oxygen per deciliter of plasma per millimeters of mercury. And so there, again, the hemoglobin is being the predominant serving as a predominant carrier of oxygen within the circulation. And when we show this quantitatively, you can see that we've got about 1.34 mils of oxygen per gram of hemoglobin, 15 grams of hemoglobin per deciliter of blood, with its saturation being dependent on the partial pressure of oxygen. And we'll get into that calculation here. But you can see here that already we're from an overall capacity perspective, the collective capacity of hemoglobin to carry oxygen far exceeds that of plasma. So when we start to look at the partial pressure of oxygen now, you can see that we'll start to go through some of these calculations and assumptions. So the barometric pressure at sea level, we will assume that's right around 747 millimeters of mercury. The percentage of oxygen in most areas is 21%. So that would, the purist would say it's 20.9%, but we'll say it's 21% in most areas of the planet. And the loss of pressure that's due to humidification in the airway or mixing with dead space is roughly 47 millimeters of mercury. So you can see this choosing of 747 millimeters of mercury. It's not only accurate, but also it also works out convenient for some simplified math here. So what you can see here is that when we're looking at the effective driving pressure for oxygen, we've got 747 millimeters of mercury of driving pressure minus 47 millimeters of mercury due to the humidification of the airway and mixing with dead space. That gives you a 700 millimeters of mercury effective driving pressure. Now, once we have that, we can plug that into to this equation down here that will ultimately enable us. This is the ideal alveolar gas equation. This will enable us to have a much more accurate estimate of what the alveolar partial pressure of oxygen will be. And so you can see that we've got 700 times 0.21. Which is that fractional percentage of oxygen in the atmosphere. So 700 times 0.21, which would give you the alveolar PO2. And then when we take and we plug in the remaining portion of this equation, which is the 147 millimeters of mercury minus 47 millimeters of mercury. If you take this and plug in numbers such as PaCO2 of 38 to 40 and a respiratory quotient of between 0.8 and 1, essentially you get approximately another 47 millimeters of mercury drop in PO2, and ultimately that gives you roughly 100 millimeters of mercury effective pressure in the alveolus if PaCO2 is equal to 38. And so you can see that overall you have a pretty significant drop in alveolar PO2 as compared to what you would have outside without humidification, without mixing in airway or dead space. And again, just really sort of depicted here properly. So you should be able to apply this equation very adeptly for the exam. Now, when you get that the PO2 of roughly 100 millimeters of mercury, that enables you to go to things like the oxyhemoglobin dissociation curve. And what you can see here is that with increases in PO2, we've got this somewhat sigmoidal curve that we have very rapid increases and very substantial increases in oxyhemoglobin association, oxyhemoglobin saturation at relatively low levels of PO2. So a very steep increase here. But then as we get above roughly 50 to 60 millimeters of mercury, we start to get a flattening out of this curve a little bit more. But when we get all the way up to around 100 millimeters of mercury, which is roughly what we would calculate our alveolar partial pressure of oxygen to be at sea level, you can see that we're actually getting about 98% saturation of hemoglobin, and which is great, because that would mean that we can actually have pretty sizable drops in partial pressure of oxygen without having substantial compromise of oxyhemoglobin saturation. Of course, now once we get to a point, let's say later in the circulation, where you go to very metabolically active tissues, you can see here that as the PO2 drops in those tissues, we can very readily unload oxygen off the hemoglobin. So this steep curve over here is actually very beneficial for offloading oxygen at metabolically active sites. Now, of course, reciprocally, if you go to very high altitude, what you can see is at moderate altitude, you'll be just functionally doing relatively well. If you get to very high altitude, where you get past the shoulder on the oxyhemoglobin dissociation curve, you'll have very precipitous drops in oxygen delivery, and that's where you have the most profound impairment, both cognitive function as well as physical performance. Now, when you look at things that also, let's say, enable the dissociation of oxygen from hemoglobin and are physiologically relevant, if you have reductions in pH, increases in temperature, for example, as you would have in exercising muscle, you can see here that it's going to enable the unloading of oxygen off of hemoglobin. Similarly, and sort of inversely, if you have increases in pH or reductions in temperatures, that'll make it more difficult to offload oxygen from hemoglobin. So now, again, when we come back and we say, well, what's the major carrier of oxygen in the blood? Hemoglobin being 1.34 mils of oxygen per gram of hemoglobin, 15 grams of hemoglobin per deciliter of blood, 1.34 times 15 times 98% saturation, which is calculated based off of alveolar partial pressure of oxygen of being 100. We get about 19.7 mils of oxygen per deciliter, 19.7 mils of oxygen per deciliter of blood. Now, when we look at plasma and we want to quantitate exactly how much is being carried on plasma, again, this is proportional to the partial pressure of oxygen. Calculations are a bit more simplistic. So we've got the barometric pressure of oxygen at sea level, the percentage of oxygen, the loss of pressure due to the humidification in the airway with the dead space, and then the subsequent application of the ideal alveolar gas equation. So that puts us with an alveolar PO2, again, of roughly 100 millimeters of mercury, as we calculated previously. So 100 times 0.003 equals 0.3 mils of oxygen per deciliter of blood. And again, so then when we take that all together, when we say, well, quantitatively, what is the major carrier of oxygen in the blood? Hemoglobin is weighing in at about 19.7. Plasma is at about 0.3 for a total oxygen carrying capacity at sea level of 20 mils of oxygen per deciliter of blood. So I think, again, collectively here, what I want to make sure of is that you can effectively apply these equations, just and expeditiously do so for your qualifying exam and for your final exam of the cardiovascular section, to be able to show quantitatively what happens to oxygen delivery and oxygen content, and what are the implications of that systemically. So our somewhat interim summary here. So we've got our vasculature being arranged in parallel, delivering nutrients, removing waste, optimizing diffusion distance. Our normal values of cardiac output and oxygen consumption are going to be about 5 liters per minute and 200.250 liters or quarter liter per minute, respectively. And again, importantly, as we start to move back towards core concepts like the Fick equation that we can use to run through all these calculations, the difference between an oxygen and arterial oxygen content and venous oxygen content is the amount of oxygen consumed. And of course, there is conservation of mass in the circulation, so we're not losing oxygen out of our skin or anything like that. It's got to be conserved throughout the entire system. And when we come back to the Fick principle, we've got cardiac output equal to oxygen consumption divided by the arteriovenous oxygen difference. We do a little bit of moving of equations around, and of course we get 5 liters per minute cardiac output, 250 mils of oxygen per minute being consumed with oxygen consumption. Our AVO2 difference is going to end up being about 5 mils of oxygen per deciliter of blood. So again, if you recall back, just to reinforce the concept that with having roughly 20 mils of oxygen per deciliter of blood in total, we've got a pretty substantial buffer for sort of immediate oxygen demand in the case of immediate onset high-intensity exercise. That will enable us to have a significant reserve and not exhaust our oxygen stores in the perfusing vasculature. So again, what I think you should be able to do, calculate the oxygen content of if given a specific partial pressure of oxygen or a specific barometric pressure. I'll provide you with additional information regarding respiratory quotient and general PaCO2 or the arterial PaCO2. But beyond that, you should be able to adeptly apply the ideal alveolar gas equation, and then calculate what changes in cardiac output or other adaptations as blood flow distribution have to occur to meet oxygen consumption demands. And again, I would really just reinforce the need to be able to do this quantitatively to show the responses to physiological perturbations. So if you can qualitatively do that, that's great. That'll get you part of the way there. But in the absence of the quantitative application of the equations that I've showed you guys throughout the course, it's going to be really difficult for you to do well on the exam. And so I would encourage you to practice as much as you can applying those equations across a variety of scenarios. So with that, thank you for your attention. This is a brief one today, and we'll look forward to seeing everybody in the course discussion. Thank you.